Thank you for joining us for our first COVID media update session for this year. Do we have someone whose microphone is on?
Yes, please mute your end.
Okay. Okay, we'll get everyone muted and everyone's recording. So we'll get started. We have Dr. Cliff Robertson, our president and CEO, who will be starting our call. Who will then be joined by Dr. Ryan Parker, who's head of our emergency medicine group for St. Francis Health System. Please put your questions in the comments or the chat, or you can have a group question session at the end if you just want to speak them. So I'll turn it over to Cliff.
Thanks, Lauren, and thanks all of you. I'm very sorry that we are back together in this virtual meeting, because it obviously means that we've seen COVID take a turn for the worst. So like I've done in the prior calls, I just want to run through a few data points. Sivan will bring some slides up and I'll just speak to those quickly. I don't want to take too much time, because we are blessed to have Dr. Ryan Parker, who leads our emergency department and our physician group that runs our emergency services, and she's better able to give you some kind of real and more pertinent of information. So the slide before you is again something that we published that's on our internet. Just shows you where we are in terms of the number of patients that are admitted with the COVID diagnosis. And as you can tell, we are unfortunately back on an uptick. The next slide will show you compared to last year. So again, the blue line is 2020, the red line is 2021. And so that shows you through the end of the calendar year where we were relative to the number of people admitted in the hospital. The next slide will just again show you where we are a little bit different. It's not graphically, but also highlight we do have people on requiring mechanical ventilation on the ventilator. That number is now 38. The cohort of these folks does tend to stay younger than we saw the first go around, and the average age of patients on the ventilator is 57.
What?
Well,
Sorry,
the average age,
I'm trying right now, but I'm also trying to get the information.
the average age of all of the inpatients is up around 62. Then the next slide, I think, is the last one. This just shows you the daily number of positive tests that have come out of our lab. So so this gives you that idea of test positivity, and specifically on the 3rd of January, so yesterday, we were at a 35% overall positivity rate, which is the highest we've seen since COVID started. So looking back to August of 21, at that peak, we were at a 31% positive. We were 33% back in December of 2020. But this Omicron variant, which the state has now released some data that suggests it's over half of the infections that we're seeing, is very contagious and does seem to be spreading pretty rapidly through our community. The one last thing I'll say before I turn it over to Dr. Parker is, we do have an ambulatory testing station, our Elm Street location. As you might expect, we've seen a pretty substantial increase in demand for testing. We are accommodating that testing. There have been some wait times. We know that, but we're doing our best to get everybody through. The turnaround time for tests coming out of our Elm Street location, about 10% of the tests we can actually deal with locally there, and those turnaround times are very quick. The other 90% of those tests come to our main lab at the Yale campus, and those are turned around, within 24 hours. So generally, folks that'll come to us for testing, we can get them an answer within a day, and that we've been able to maintain, even though the demand has surged pretty substantially over the last couple of weeks. So I'll stop there and turn it over to Dr. Parker, and then we'll take any questions you might have after she's finished.
And I just want to clarify one thing that Dr. Robertson said. Our main lab at St. Francis Hospital is where the tests are processed. That is not a testing site or center. Patients shouldn't come to the main lab for testing. That would be the testing location on Elm Place in Broken Arrow.
Thanks, Lauren.
Well, thank you, guys. As Dr. Robertson said, I am the director of our emergency departments here at St. Francis. And I was thinking back our first meeting together back in August, where Cliff and I gave you the update of our system. And it is a bit like deja vu. So giving you an idea of the state of the union of the ED, it looks very crowded. We have had sort of stable volumes for the last several weeks, comparatively to our surge in August and the summer surge. And you can feel that as patients. The waiting rooms, we have long length of stays. Our hallways are starting to be utilized again with patients, and we are working very hard to balance the ambulance patients coming in, the patients walking in the front door for emergency care, and also some inpatients that are holding in our emergency departments because of how full we are in the hospital. Be patient with us is what we would ask you. We are doing the best that we can. I think the one big difference between this surge and last surge is that we continue to work on staffing in the hospital, and it's affecting all of our departments. You can imagine this is our third surge since we started the COVID pandemic. And I spoke with you last time about our staff feeling fatigued and overworked and overwhelmed with the amount of patients and just the emotional capacity that it takes to deal with this kind of stress for an extended period of time. And we're still dealing with that. And so our teams have shrunk even a little more, but we are working together. The thing about people who go into emergency medicine or critical care, or this acute care kind of taking care of hospitalized patients, is that we are very tough people, and we know how to rally together and do what we need to do to take care of the patients. So know that we are here for you, but it is very crowded. So just like we spoke with last time, we have the same recommendations. We would love to give you boosters and vaccines. This is the main thing that is helping this process and helping our patients. I took care of a couple, I worked over the weekend, and I took care of a couple of elderly patients that were boosted. And even though they had a breakthrough infection, their chest x-ray was clear. So we do know that it is affecting severe disease and that need to be on the ventilator. However, in that same weekend, I took care of some unvaccinated patients who were still having severe respiratory processes and needing to be intubated and placed on BiPAP and have their respirations supported. And so I want to acknowledge that Omicron, like you see on our graphs, the hospitalizations are less compared to our winter surge from last year, but we are still seeing very ill respiratory patients. So I would just put that out to the community that we still need you to get vaccinated. Please wear a mask when you're around other people. Wash your hands and social distance when you're in crowds. So same recommendations. We do have some new outpatient treatments. We've been doing monoclonal antibody infusions since our summer surge, and we now have a few more options that we're working to get, but the manufacturing of those options, obviously this is a fluid process, so we're still building our stores of those medications. And then just my last sort of plea or recommendation is that in the emergency department, we are good at taking care of all sorts of things, not just those traumas and strokes and COVID respiratory distresses, but we take care of some urgent things. And I want to just reiterate that we have an amazing urgent care system and virtual urgent care, that if you're having symptoms, they can arrange for you to get a test. If you're not having respiratory distress or having anything that you consider an emergency and just want to be tested for COVID, you can arrange for a video visit and get that test at one of our drive-thrus. So it's very convenient for you. Thank you.
Thanks, Dr. Parker. And I will just reiterate one thing. I know this question has come up before about, well, are you at that place where you need to stop, scheduling surgeries, et cetera? And if there's nothing else that we've learned through the last couple of years is we don't do ourselves any favor. More importantly, we don't do the community any favor by encouraging patients not to seek the care that they need. So at this point, we don't have any desire or plans to begin restricting services, because we do actually want folks to, that are scheduled for procedures, that need care, to please access that care. Because quite frankly, it doesn't help us for a bunch of folks to take, 3 or 4 weeks off and then get sick enough to end up being back in our emergency room for other reasons other than COVID, because they didn't seek the care that they needed. So it is a balancing act that we're trying to walk very carefully, but we do want people that need care be seen in the clinic, use the urgent care. If you're significantly ill, come to the emergency room and we will take care of you, as Dr. Parker said, because we really don't want any other bad outcomes as a result of delayed care. So I think we'll stop there, and Lauren, if there are any questions, we're happy to answer them.
Yeah, we have quite a few questions in the comments, many of which we've already covered. One of the ones that you just covered was, when should people go to the ER and when should they seek other services? I think that's a question that we've gotten a lot. Cliff just did a nice job of explaining when it's an emergency that you should go to the emergency room. I'm not sure, Dr. Parker, if you'd like to add any other information to that answer.
Sure. If you're experiencing symptoms of trouble breathing or chest pain or severe nausea and vomiting, weakness on one side, that's stroke-like symptoms, I think most people are aware of, if it feels like an emergency to you, you need to come be seen by a qualified medical professional to determine, yes, this is an emergency or not. So you don't need to take that on your own necessarily. But if we have quite a few patients who are just coming for COVID testing, and we are happy to see you, but you're going to wait a little bit if you come to the emergency department for that, because we triage based on your acuity, how sick you are. And so we have to take the sicker patients to the back first. So that means some people can have a very long wait in our waiting room. If you are just coming for a COVID test, we have multiple other avenues that we can get you in much more efficiently and more comfortably for you.
Thank you. And the other thing that I throw in there is that we do have a 24/7 virtual urgent care service that 24 hours a day you can access one of our physicians who is a Tulsa-based physician, that you can have a visit online on your phone that is an urgent care visit, and they can help you decide if they can't make a diagnosis or offer treatment recommendations on the video visit, they can refer you to come in to see someone in person if needed. Then going down the list, are we doing our own sequencing to see how many of our patients are Omicron? I think we do have.
Yeah, no, the answer to that is we're not. That is being done by the state lab.
We might, I think we have a percentage of what our patients are for Omicron that we got back that I can look into.
I think the release today from Oklahoma State Department of Health, and they sequence the sequences over the holiday showed 57% Omicron and 43% Delta.
What is our average ER wait time? I think our wait times vary by hour, by day. Dr. Parker, do you want to comment on that?
They do, and it just depends. We are working in every creative way possible to move our patients through. So, I usually tell my patients when they present in the ER that it's going to be anywhere from a 3 to 6 hour stay with me when you're here. But obviously, sometimes it's much longer. Sometimes it's a little less if it's something that we can quickly and efficiently get taken care of for you. And obviously, if you're very, very ill and it's really acute, it's trauma, it's a heart attack, we get you in, in less than an hour upstairs where you need to be to the cath lab or whatever. So we're really quick at the things we need to be quick on, but if you're less acute, you may wait for several hours. we have several processes in the emergency department. Just like I talked to you about in August, it's not just you present to the waiting room, go to triage, go to a bed, and then get discharged or go upstairs. We have something called results pending. We are trying to see sort of more fast track and urgent care type patients. Sometimes you'll even be seen in the triage bays. Sometimes we'll go and pull you out of the waiting room and see you. So we are really working in every capacity to try to do what we can to move people through.
And that kind of relates to Amy's question about us using hallways for some patients who we aren't able to get into a room. She thought that the governor had to declare a state of emergency for that to happen. I'm not familiar with what that might be referring to. Do you want to talk about when patients go in a hallway?
Sure. We do everything we can to try to, get people the private rooms and everything, because we want you to be comfortable. But obviously, we've got to do what we need to do to take care of you in the moment. And if sometimes that's not always as comfortable as we would like it to be, but we're giving you the care that you need, right? And so sometimes if we get a surge of ambulances, we don't get to shut our doors and say, oh, we're full, we can't take anymore. We have to take care of everybody who comes to our door. And so, if there aren't enough private rooms available, yeah, we start overflowing into the hallway. Because we do what we have to do.
Here's another question from Fox 23. Do you believe that the reports that Omicron has milder symptoms have given people a false sense of security?
Yes, personally, I do. I'm for those people who are high risk. You still could have a very critical course with COVID, and we just got an announcement that we had our first flu death in Tulsa. So any virus can be very detrimental to immunocompromised and people at risk. So I think it is a disservice to sort of promote that this is, milder. Yes, it's milder, but for some people it's still very dangerous. And it is our duty to kind of, we're our brother's keeper. We need to protect our neighbors. And so I think it sort of gave people the idea, oh, it's okay to get out. Oh, it's okay to have like huge family gatherings. Oh, it's okay to go, sit at the football stadium without my mask on. And I think that sort of propagated this surge that we're seeing now.
And then this is to either Dr. Parker or Dr. Robertson. Compare the numbers for St. Francis Hospital in Muskogee to St. Francis Hospital in Tulsa, wait times, patients seen. I'm not sure if you're looking at just specifics on what's going to which hospital. I think that's Chris that asked that question.
Well, I'll speak to it more generally, and I don't know if Ryan, you can speak to it more specifically, but generally you're seeing that there's really no difference. What we're seeing in Muskogee in terms of the demand, the need for care in terms of numbers of patients has increased rapidly over the last few weeks. And it's a very similar scenario, maybe on just a slightly smaller scale because it's a slightly smaller community. I think the findings in terms of the degree of severity of patients we're also seeing is very comparable in Muskogee to what we see in Tulsa. So I don't know that there's much difference, nor should we expect that much of a difference. Ryan, I don't know if Dr. Parker, can you speak?
Oh, I agree. And partially, we in the emergency department, we staff per sort of a volume ratio. So we staff the same amount per volume at each site. So with our physicians and APPs and nurses, they do have less total patients, but we want to have enough physicians, nurses, techs, medics, everybody is staffed to the same ratio. And so as far as patient population, I mean, there are different characteristics to different patient populations. So there is a little bit more vaccine hesitancy in the rural areas. And there are certain health conditions that are a little more prevalent in the rural areas. So sometimes the disease presentations may be a little different, but how we respond to them is not. You get the same care in Tulsa as you do in Muskogee. And in fact, a lot of our physicians work at all of our ED in St. Francis. It's standardized. So for instance, I work here in Muskogee. We have several people that go back and forth. So you're getting the same care.
And then here's a question from Chris Polanski. Next door in Arkansas, the governor today said that the state is in the period of, quote, probably the greatest risk and greatest challenge we have faced during the pandemic. Is that our assessment here in Tulsa and Muskogee at this point as well?
You know, I don't know that I could answer that question specifically. What I would say is that there are things that are different now than there were 18 months ago. One, obviously, we've seen more of our staff either decide to leave the workforce or to decide to leave the local workforce and go, travel to other parts of the country. So that is different for us, and that poses new and maybe different challenges than we faced 18 months ago. It is offset by the fact that I think there's a more generalized, more general comfort with taking care of COVID patients, right? If you think back to the beginning, we didn't know what we didn't know. Now people, our caregivers, so our physicians and other caregiving staff are more comfortable understanding how to protect themselves and as well as how to care for patients. So I think that's actually, we're in a better place now than we were, nearly 2 years ago. But I do think the rapid increase in the number of cases, even if in general, the Omicron variant doesn't create the same level of disease severity, we're still seeing a large wave of patients, which in and of itself creates the challenges that Dr. Parker already alluded to, which in terms of ER wait times for folks that aren't critically ill. So it's a long way to answer your question. I don't know that we're at a worse place than we've been. I do know that, I think we're all tired of this. We didn't want to have these Zoom calls with you in 2022. Unfortunately, we are.
Yeah, I agree. I think, like Dr. Robertson said, we've learned a lot about the disease, and we're very good at it now, for better or for worse, in providing the supportive care, and we know more about the process and the treatments that are needed. But the challenge is now sort of community apathy about the things that we know that help prevent viral spread. Still vaccine hesitancy, and just like Cliff said, we're so tired, and I know the community is tired too. We had hoped we wouldn't be speaking about another surge here, and here we are. And so I think that is our challenge, but you have a team of creative and willing partners here at St. Francis. We are resuming our weekly meeting to see how we can respond in a way that is not just status quo. We want to respond creatively and effectively to what's going on.
And then we have a question from Fox 23. Do you see St. Francis recommending any new public health measures for city officials to consider, like another mask mandate?
Well, I might have a different perspective than Dr. Parker, but I'll give you at least Cliff Robertson's perspective. What we're learning, particularly with this variant, we see it in our own employee data. So as of the beginning of this week, we had about a little less than 60 of our staff that were out with COVID. Over half were fully vaccinated. So unfortunately, with this variant, it is infecting people that are fully vaccinated. So it's, the vaccine isn't going to prevent people from getting infected, which then means we all have to be doubly thoughtful about social distancing, about how we, protect not only ourselves, but our family members. Again, most of the spread that you see with this COVID, and this has been pretty consistent over the last 18 months, is really happening within households. It's close contact, it's close prolonged contact. And so we can't forget those facts. Do things like masks help? Yes, we absolutely believe they help. Obviously, we require them inside our hospitals for both our, our patients and our caregivers, but they're not fail-safe. And so I think it's back to Dr. Parker's point of, we are our brother's keepers. And so we just need to be very thoughtful about the things that we do that may put ourselves at risk, and maybe even more importantly, put those that we love that are higher, that are at risk for other reasons, put them at higher risk. We have to be very thoughtful about those things.
I agree. I think that, we have seen several times that mandating things seems to cause distraction from what we're actually working to achieve, which is to take care of our community and take care of each other. And I think from my perspective, you shouldn't have to force someone to do the right thing. And if you feel ill, sorry, my East Texas came out just a little bit there, I apologize. If you feel ill, please don't go out in public. If you've got a fever, don't send your kids to school. Wear a mask if you're coughing, because it protects other people from your respiratory droplets. I just think be aware of what we're going through as a community. And, I think that the vaccine is protecting against severe illness, but we take care of every kind. And I ask always, are you vaccinated or not? Because it helps me sort of in my medical care, but I always put in there, no judgment. You do what you need to do as a human being, but I can tell you that it's effective and it's preventing severe illness and being on the ventilator. And talk to your doctor, talk to your healthcare provider if you have questions or fears still. But we just need to take care of each other throughout this surge and protect our community.
We got a question while you were answering the last one about what would you tell someone who was fully vaccinated, who had the "it can't happen to me" attitude. I think you just answered that. I'm not sure if you want to add anything else to that.
Well, I would just say, vaccines are not a one and done. We know this from all the childhood vaccines that we have. We get a flu shot every year. I get a flu shot every year. I get my tetanus updated and I update that for my patients. So fully vaccinated is a little bit of a tricky statement, because what we're learning about COVID is probably going to end up with the same vaccine schedule like some of the other vaccines, where you get a yearly booster. And so we know that it's effective for preventing serious illness. And I think that if you've had 2 shots or even a booster, it is not abnormal in viral infections or with immunized patients to have breakthrough. That's the normal cycle of viruses, but it does prevent you from getting as ill. So I would say that "it can't happen to me" attitude, you still need to wash your hands and cover your mouth, just like your mom taught you, and do basic kind of principles to help prevent illness.
Thank you. Looks like we've covered all of the questions and we're almost at the top of the hour. If there aren't any additional questions coming in the chat, thank you all for participating. If you have any additional questions, you can contact